I'm going to analyze another scene from the HBO Max series, The Pitt. As I told you before, this is, I think, an important show that really dramatizes as close as possible what it's like in some of these situations. And I have a special affinity for it because it's set in Pittsburgh and it's set at the same hospital that I did my combined internal and emergency medicine residency at. So let's see what this scene has to offer.
The antibiotics should clear everything up, but you should try to stay off it for a few days.
I have to work. I'm late as it is.
Well,
So what we're seeing is a young female presenting with redness and pain to her lower extremity. So this is something that's very, very common, and it has the diagnosis of, or the name of cellulitis, which is infection of the skin and the skin structures underlying it. It's very common, and it's usually something that you can treat with ordinary antibiotics, and people get better over a period of days. You tell people to take the antibiotics, maybe anti-inflammatories to raise their leg so that some of the swelling goes down, and they usually get better on their own. It's not something that's usually life-threatening, and it's something that many people will have already experienced. And that's basically what we're seeing right now is he's giving her antibiotics. There's a red leg that is consistent with cellulitis.
take breaks and elevate when you can. Tylenol and Advil for the pain. If the pain persists or feel like it's getting worse, come on back, we'll get you fixed up.
Thanks.
So he's telling her if the pain persists or gets worse to come back. That tells you that the cellulitis is progressing, that it's not just a simple infection, that it might be involving deeper structures, it might be spreading systemically. So you want those people to have the ability to come back very quickly, to be assessed to see, is this going the right way or the wrong way? It's also important to know that the antibiotics aren't going to magically work with one dose. It's going to take a couple of doses of the antibiotics to reach kind of steady state in your body, and then start to see the redness, the swelling, the pain come down. And also anti-inflammatory medications like he's recommending, ibuprofen, for example, will also help with that. Some people actually even give steroids to get this better along with antibiotics. And what are the bacteria that cause cellulitis? It's usually the bacteria that live on your skin and get access to the deeper structures of your skin through little microabrasions, little cuts. And it's usually going to be strep. It's almost always strep that is the infection. Sometimes staph, including MRSA, can cause cellulitis, but strep is usually the most common cause. There's obviously exotic kinds that you can get if you're in fresh water, if you're in brackish water, that might be something more unusual. But in this case, this is a garden variety type of cellulitis that we're seeing in this scene.
Yo,
What's up?
I got a bounce back. You remember Debbie Cohen?
Not really. I've seen 16 patients this morning.
The restaurant worker with cellulitis on the dorsum of the foot?
Yes, she's on Keflex. I marked the orders.
Yeah, I got a humpback on it, but you should take a look.
Now we're hearing that she is bounced back. That's kind of a common emergency department lingo that says someone that was just discharged or discharged recently is now coming back. They're bouncing back. And he's saying, she was on Keflex. Keflex is a very common antibiotic that would cover strep. And he said he marked it. So oftentimes with cellulitis, a doctor might take a marker and mark the area of redness to try and see, is it spreading outside that border? So now this woman has come back. We'll have to see what exactly brought her back.
You should take a look.
Hi, Dr. Langdon.
I wasn't expecting to see you back so soon. Meds upset your stomach?
No, the pain got worse, and you said to come back if the redness spread outside the Sharpie line.
Let's take a look.
So now what you're seeing is this woman clearly is in more pain. She's having pain with him just moving the dressing that's been put over her foot. And the redness that you see there has now expanded beyond the border with the Sharpie marker that he drew. And she's come back because that's what she was told to do, to come back if it got worse, if it spread outside those borders. So that tells you that this is progressing, that this isn't going the correct way. And while I said it takes a couple of days for antibiotics to work for cellulitis, it shouldn't get worse. The fact that it's getting worse makes you think, what's going on here? Did I give the wrong drug? Did I make the wrong diagnosis? Is this deeper than just a simple cellulitis? Why is this moving faster than the antibiotics? How do I get back on top of this? That's what needs to be thought of in this type of situation. And when you're dealing with an infection that's rapidly spreading, it always has to be in your mind, is this person going to get septic? And sepsis, a dysregulated immune response to the infection, which can lead to organ failure. So it means your immune system goes haywire when it's dealing with an infection, and it can cause you to have low blood pressure. It can cause you to have mental status changes. It can cause you to have organ failure, and it is a cause of death. It's the final common pathway for many infectious organisms to kill you is to cause sepsis. So anytime you're dealing with an infection as a provider, as a physician, you have to think, is this sepsis? Is this progressing to sepsis? Do I need to augment my care in order to make sure that I'm dealing with the sepsis as well?
It looks like the infection isn't responding to the pills I prescribed you, so we need to get you on some IV antibiotics and get you back to the ED now.
Is it bad?
Not if we can get a handle on it.
Now Dr. Langdon is saying we need to get her back to the main part of the emergency department and put her on IV antibiotics. So what's the advantage to IV antibiotics? They're not magic, but what it does ensure is that you're actually getting the antibiotic to the site of infection. So most oral antibiotics give you good tissue concentrations, meaning the antibiotic gets to the area of infection. But some of them are not 100%, meaning that if you take a pill, it's X milligrams, maybe only a fraction of that is actually what we call bioavailable, getting to the site of infection. There are some antibiotics, for example, ciprofloxacin, or Cipro as you might know it, that are basically the same IV and oral, but Keflex isn't quite one that is completely 100% the same. So he's thinking, if I put this patient on IV antibiotics, more antibiotics will get delivered to the site of infection, and maybe we'll get a handle on this. And he's saying, we have to take you to a normal room to monitor you because he's worried about progression, that it hasn't responded.
MRSA, or maybe worse.
So now he says MRSA or maybe something worse. So MRSA is MRSA, or methicillin-resistant Staphylococcus aureus. That is a very common infection, bacteria that causes infection. So it's a type of Staph aureus that's become resistant to certain antibiotics, and it's very common in skin infections. It's a very common infection to see. But one of the things that's characteristic about MRSA infections, especially when they're causing cellulitis, is that it looks kind of weepy and draining and with pus coming out of it. And her leg doesn't look like that. So I don't think that this is going to be MRSA or as consistent with MRSA, but obviously you have to think about that. You have to consider that. And when he says something worse, what could that mean? Not necessarily a worse type of bacteria, but a worse type of condition than cellulitis, one that is deeper, one that is more rapidly spreading. And we're going to get to that shortly.
Hanging Vanco.
What's Vanco?
Really strong antibiotic to kill skin germs.
Need a hand?
No, we got this.
I'll just observe.
Now he's talked about using vancomycin, which is a different antibiotic that is administered intravenously and does target MRSA as well as streptococcus. So he's changing the antibiotics. What we're doing here is called escalation of antibiotics to try and get a handle on this infection.
Pretend I'm not even here.
Let's send off a CBC, blood cultures, and CMP.
And also lactic acid, CRP, and calcitonin.
But she's not febrile, not tachycardic, no evidence of SIRS.
So he's now rattling off certain blood tests to do. He says CBC, that stands for complete blood count. So that's going to look at the number of white blood cells that are in her blood, which when it's very high or very low, that can be suggestive of infection in the types of white blood cells. If there are lots of immature white blood cells, for example, in the CBC, that tells you that she's fighting an infection because the bone marrow is now pumping out immature fighters to try and combat this infection. Asking for a comprehensive metabolic panel or a CMP, that's going to look at her electrolytes, her liver tests, her kidney function to see, does she have end organ damage? Does she have dehydration on top of this? Does she have kidney injury? They're also going to ask for blood cultures. So blood cultures are basically large bottles that look like small wine bottles that they incubate blood in to see if a bacteria, if a fungus grows in them, because they're worried this infection has now spread from her leg into her bloodstream. And then Noah Wiley's character, Dr. Robbie, is asking for a few other things. Lactic acid. This is something because he's now thinking about sepsis. He's thinking, can this patient have sepsis? And lactic acid is one of those markers. If it's elevated, it shows that she's not perfusing. She's not getting the nutrients to her tissues, and lactic acid starts to build up. That same lactic acid that builds up when you're exercising, that pain, that same type of metabolite will go up when you have impaired organ function from sepsis. He's asking for a CRP. That stands for C-reactive protein. That is an inflammatory marker that your immune system sends out when there is a battle going on. And he asks for procalcitonin as well, which is a marker for bacterial infection. It goes up with bacterial infections. So what they're doing right now is really being aggressive, or trying to be aggressive, to figure out, why is this patient not responding to the antibiotics? How sick is she? And Dr. Langdon is starting to rattle off, well, she's not having a fast heart rate. She doesn't look like she's septic now. But a person might not look septic just by looking at them. That's what these biomarkers do. They give you more insight to what's going on internally, even if the patient doesn't have a fast heart rate, doesn't have a fever, doesn't have low blood pressure. They still might be septic. And that's what these biomarkers are going to help to uncover.
Tachycardic, no evidence of SIRS. Yep.
What's SIRS?
Systemic inflammatory response syndrome. Sorry.
So they're talking about something here called SIRS. I was talking about sepsis earlier. SIRS stands for systemic inflammatory response syndrome. And when you have SIRS caused by an infection, that's basically one of the definitions for sepsis. So SIRS refers to how your body is responding to some sort of insult. And SIRS doesn't have to be caused by an infection. It can be caused by many different things. If you're in a traumatic accident, you will meet SIRS criteria. So what is SIRS? What are the criteria? So a certain heart rate. If your heart rate is above 90, if your white blood cell count is above a certain threshold or below a certain threshold, if your respiratory rate is faster than the normal number. These are kind of a checklist that you go down to say, does this patient meet SIRS criteria? And if they meet SIRS criteria, then you think there's an infection present. You think, could this be something that is going to be sepsis? And what do I need to do to countervene it? That's what SIRS criteria are. It's just a kind of a quick and dirty way to tell whether or not someone has it. So do they have a fever? Is their heart rate above a certain threshold? Is their white blood cell count above a certain threshold? And is their respiratory rate above a certain threshold? Those are the criteria that we use. And it's not important to memorize them or for me to go through them in detail, but that's just a screen that people use. And if there's an infection suspected, then you think this is sepsis.
Sorry.
An exaggerated defense response.
Sorry, what?
Sometimes the human body can have an overreaction to an infection, so we're going to monitor you to make sure that this does not progress.
So they're talking about exactly what I was mentioning earlier, an exaggerated response to an infection. So that's what I mean by sepsis causing a dysregulated immune response, that the immune response is exaggerated, which then puts the person's life at risk, which then puts organ function at risk. So that's what's happening with SIRS. That's what's happening with sepsis. That's what they're looking for.
It's my boss. Sorry, I have to take this or he's gonna fire me. Hello? No, I'm still at the hospital. Being seen right now. Ow. No, they just stuck me with a needle. I don't know. You want to talk to them? They're kind of busy right now. I know you are.
Second IV's in.
Well, I'm not overreacting. My body's overreacting. Please don't fire me.
This is Dr. Michael Rabinovich. I am the chief of emergency medicine at PTMC. If you fire her, she will sue you, and I will testify on her behalf. Okay. Don't worry about it. We got you. I am getting concerned. This is a millimeter past the line.
Or my line was sloppy.
Any increase in pain?
Oh.
Okay, sorry. This is trifluoromorphine.
White count's only 10,000. It'd be over 12 for SIRS.
So now Dr. Robbie is saying that the redness has progressed past that Sharpie line, which we heard about before. And you see the other doctor kind of saying, well, maybe she's not that sick. Maybe I drew the line sloppily. But clearly, that's added for dramatic effect. It's very obvious. This is a barn door diagnosis that this isn't going the right way. And now you're hearing that the white blood cell count is 10,000. So that technically is not very high. It's not very impressive. It's not a low white blood cell count. It's just kind of in the middling range. So you don't always get everything to be exactly consistent when you're dealing with a patient in front of you. It's not always going to be textbook, like a white blood cell count of 20,000. So the white blood cell count is 10,000. That's kind of equivocal, but again, you have to look at the patient in front of you and you see progression. So that white blood cell count is not what you're treating. You're treating the patient in front of you, and you're seeing that this patient definitely has progression. So you need to continue your assessment and workup and the IV antibiotics.
Over 12 for SIRS.
There are other criteria.
Still afebrile.
Did you ask about past history of MRSA?
Not specifically, but she's never been hospitalized.
Any evidence of an immunocompromised state?
No, she's healthy.
Steroid use?
Never.
Maximum heart rate's only 89.
Is that okay?
So now you're hearing them rattle off some of the other SIRS criteria, that she's not febrile, she doesn't have a fever, she's not tachycardic, her heart rate is normal, it's not above that threshold of 90 that we use for SIRS. And Dr. Robbie's asking, does she have a history of MRSA? And you're hearing that she's never been hospitalized. That's because hospitalization is a risk factor for getting colonized with MRSA. He's asking if she has any immunocompromising conditions, because that would put her at risk for having a more severe infection or having an infection progress faster. So these are all important things to know about when you're dealing with the patient, trying to figure out why they're not getting better and why they seemingly are getting worse.
Is that okay?
That's good, very good.
Stay with her, monitor her closely. If there's any change in her condition, come find me. I mean, any change.
Roxy Hamler, 42.
Cycling the BP.
Okay, this redness is now a centimeter over that line, and this might be Ebola forming.
Vanco takes a little time to work.
Vital signs are still stable, 122/78.
Now you're seeing an evaluation of the leg again, and there's still more redness or erythema spreading beyond that border. This tells you that this is progressing. And he's noticing a bulla form. That's kind of when the layers of the skin separate and you get fluid there. That's a sign that this infection is more severe, that it's causing more skin damage, and that's raising the stakes. But yet they're still not seeing her blood pressure drop, for example, which you would expect in septic shock or severe sepsis. But remember, those might be late findings. It may take some time. A person has a certain physiological reserve, and then they don't. So the blood pressure may be normal until it's not. So I think it's really important to, again, not focus on specific things like that. You've got to look at the whole picture of what's going on here.
I got it.
How are you feeling, Debbie?
I'm feeling a little warm.
That can happen with Vanco.
Thanks, man. Lactic acid 4.2.
So a couple of other things. She's on vancomycin right now, and Dr. Langdon had just said it takes a little bit of time for Vanco to work. That's probably not the right answer here, because again, one dose of IV antibiotics isn't magic, and she's progressing, and you can't expect the Vanco to do anything immediately. Number two, she feels a little warm. That could be a sign of fever, which could be a sign of sepsis. It's a SIRS criteria. But also vancomycin, sometimes when you infuse it, it causes people to feel warm. So that's what Langdon is saying. And in this, there's a lot of drama here between the two doctors, and it kind of makes Dr. Langdon look bad because he's saying things that are not he's a third-year resident. He knows better than to be saying these things, but I guess they're doing this for dramatic effect to have him opposed to Dr. Robbie. But some of the things he's saying don't really make sense for a third-year resident to be saying.
Okay.
What's wrong?
That can be a sign of a more serious infection, but the good news is we know what to do. Jesse, 2 liters of LR wide open.
This is severe sepsis.
I know, but at 7 a.m. it was a simple cellulitis. Anyone want to give her Keflex?
Dr. Langdon is now giving 2 liters of LR. That's lactated ringers. That's a type of IV fluid. That's part of what you do in sepsis patients, is give them fluid in order to compensate for the physiologic derangements that are occurring. So it's very standard when someone has sepsis to make sure that they're adequately fluid resuscitated. So that's what those 2 liters are. And now you see them use the word sepsis. Dr. Robbie says this is severe sepsis. that's what they're recognizing now. And what Dr. Langdon replies was, well, it was a simple cellulitis. And I think that's fair, because all infections begin as a simple infection and then progress. And it's sometimes hard to know who will progress. The key thing is trying to make sure you intervene quick enough. And there's all this effort now to understand what mild infection is going to turn into sepsis. Can AI figure that out by looking at subtle changes in the blood work, subtle changes in the vital signs? That's sort of one of the holy grails for AI, is to identify patients who look fine, like a simple cellulitis, that are going to come back in a couple hours later in severe sepsis.
We could add carbapenem or zosyn to broaden our antibiotic coverage.
Okay, I got it. Thanks. Jesse.
Now you're hearing about broadening the antibiotic coverage. They're naming some other antibiotics like zosyn or meropenem. These cover lots of different organisms. So he's thinking in his mind, did we miss the organism? Is it not a simple strep cellulitis? Is this not a strep infection? That's why they're broadening antibiotics, which it's reasonable to do. She's getting worse. So you're escalating antibiotic therapy at the same time, trying to figure out what's actually causing this, what's wrong.
Jesse, 1 gram meropenem, 900 milligrams Clinda, page Dr. Garcia, please.
What's going on?
We're adding new antibiotics.
It's serious.
We want to get ahead of it and make sure it doesn't become serious. What else can I do?
I think you've done enough. You can go.
So they've asked to page Dr. Garcia. So for those of you who don't know, Dr. Garcia is a surgeon. So what does that mean they're thinking? They're thinking that this infection of her leg is progressed deeper and may need surgical intervention, meaning they may need to cut out the infection. So when you're talking about an infection like this, and one of the antibiotics he adds is clindamycin, which particularly is important here because what is in Dr. Robbie's mind now is necrotizing fasciitis, or what's sometimes commonly called flesh-eating bacteria, meaning a very rapidly progressing bacterial infection that is secreting toxins that are causing kind of the tissue to dissolve, to move very fast through that tissue plane and spread rapidly from her foot to her leg to her thigh, all the way up. That's what happens with necrotizing fasciitis. And what you need to do is consider it a surgical emergency, and you need to get a surgeon involved in order to basically cut above the infection and get all of that infected tissue out. So it's not a matter of antibiotics anymore. It's a matter of making sure that the surgeons achieve what's called source control, controlling the source of the infection.
All good in there?
How are we doing in here?
Spiked a temp to 102, gave Tylenol. Check out her leg.
That is a definite bulla. Did surgery come down yet?
Not yet.
I need surgery.
Page him again. Surgery would be a last resort. We would like them to come down and check out your leg in case we need to remove this infected skin.
I thought it was just a little swelling because I'm on my feet all day.
EP's down to 85 over 40.
So now we've seen the leg progress. Now that bulla is more ripe, you can actually see what's going on, and the skin is getting more damaged. She spiked a temperature, and now her blood pressure is dropping. So she is progressing through the stages of sepsis right in front of our eyes. And now she is basically going into severe sepsis, septic shock, which is a medical emergency. And every kind of minute someone stays in septic shock, that increases their mortality if you don't intervene. So we'll see what happens next.
How much LR is it?
Full bolus.
Another liter, and let's start Levofed titrate to a map of 65.
So he's asking for now another liter of fluid, and he's asking for a drug called Levofed. This is a medication, an adrenaline type compound that artificially increases your blood pressure. And he's targeting a MAP, which stands for mean arterial pressure of 65. So the mean arterial pressure, so you know your blood pressure, 120 over 80. The mean arterial pressure is the mean of that. And he wants 65 because that's the threshold we use to make sure organs like the kidney are getting perfused. So right now he's worried that her blood pressure is too low to support organ function. So he's taking control using a drug like Levofed in order to do that, along with IV fluids. And now you're basically seeing her in septic shock.
Can someone please tell me what's going on?
Pulse ox down to 89.
100% non-rebreather. Sometimes an infection can cause your blood pressure to drop and lower the amount of oxygen in your blood.
Am I gonna be okay?
We're doing everything that we can to make sure that you are. Jesse? What's up? Be ready to intubate if you need to.
You want me to call Langdon?
now you're seeing her oxygen levels drop. This metabolic demand from this infection is compromising her ability to breathe. It's compromising multiple organ systems. So she is now progressing to multi-organ failure. They're giving her oxygen by a non-rebreather mask in order to try and increase the amount of oxygen. There's 21% of oxygen in the ambient air. They're giving her more now to try and make sure that she's adequately oxygenating. And he's telling his colleague there, the nurse, prepare to intubate. What does intubate mean? It means put her on a mechanical ventilator to breathe for her. So this is getting bad very fast, which can happen in severe sepsis.
Call Langdon?
No, I will be right back, and you can call surgery and tell them to get their heads out of their asses and get down here. Did you bring Langdon back here?
No, Al Hashimi did. You banished him to scud purgatory. He did everything you would have done with that cellulitis patient. If you think he missed something, tell him.
He's asking for surgery to come down. This is a surgical emergency. You want the surgeons to lay hands on her leg. You want them to expedite source control by taking her to the operating room and clearing out that infection. He's also talking to Dana, the nurse, about the other physician. Did that physician miss anything? And I don't think he did miss anything. That these things happen, that someone comes in with a mild infection that gets worse. That's why you tell people to come back if things get worse, because you can't necessarily predict who's going to get sepsis, and she looked good. There was no reason to suspect it would turn into this, although you kind of countenance against that by giving good return instructions, saying if this gets worse, if the pain is worse, you draw a line around it. If it progresses, come back, because you don't know who it's going to come back on. You do in the sense sometimes when they have risk factors for severe disease. So maybe they're immunocompromised, but this person didn't have any of that.
Probably going to need to intubate. We're definitely going to need an ICU bed.
What happened?
She is in septic shock on pressors.
So he's saying now that she's in septic shock on pressors. Pressors, that refers to the Levophed that I mentioned earlier, the artificial raising of the blood pressure with a special drug. And they're going to need an ICU bed. That's where we take care of septic shock, in the intensive care unit.
Maps holding on Levophed, 1 mic per kg per minute.
Do me a favor, give me some 4x4s and some betadine.
Sorry, we're getting killed with transfers from Westbridge.
So now you're seeing the patient intubated, so she's on mechanical ventilation, so she's got respiratory failure. And now he's asking for betadine, and you see the surgeon in the room. So this is going to get very dramatic in a second.
Dark ischemia, perforated bowel.
Got a hot one here.
Yeah, possible neck fash.
Possible.
Need CT with contrast to
This is
confirm.
spreading like wildfire by the time you get your CT.
So now they've mentioned the word neck fash, necrotizing fasciitis. And the surgeon is saying possible, need a CT with IV contrast to confirm. So yes, a CT scan can help you make the definitive diagnosis, but you can't wait for something like that. And in this situation where you've got this rapidly progressing skin and soft tissue infection, now in a patient that's now in septic shock, you don't need the CT scan to give you the diagnosis. The diagnosis is right there. So this is odd that this surgeon who's very experienced would actually ask for a CT scan with IV contrast. They would not, maybe early on when she first came in back, they might ask for that to see how deep is this. But now in septic shock, intubated on pressors, it's clear that this is that. So that's a little bit added for dramatic effect to give you some conflict between the two characters, I think. But no surgeon would ask for a CT scan at this point. But yes, a CT scan would show you that this is a progressive infection. But you already know that with your own eyes and looking at her physiologic status.
By the time you get your CT, it's going to be up to her waist. She's going to need a hemicorporectomy.
She needs a CT scan.
So Dr. Robbie says by the time you get your CT scan, it's going to be up to her waist. That's what I was talking about. If you delay, this is rapidly progressing. It will literally move minute by minute. You can see it move because it is moving so fast. And he said she might need a hemicorporectomy, which means cut out half of her body, meaning her whole right lower extremity might need to be taken off if you wait that long.
Stainless steel scan.
For Christ's sake, Rabinovich. Robbie, what the fuck are you doing?
Oh, God, I think it might be pure.
That's called dirty dishwater exudate without purulence.
So what's Dr. Robbie done, and this is really maverick cowboy, I don't think anybody would ever do this, is he's now doused it with betadine to disinfect the skin, and then he's stuck a scalpel in there and cut into the skin. And you can see how easy it goes. There's not much resistance. And what comes out of it is, he calls it dirty dishwater. So that's really very characteristic of necrotizing fasciitis to have that type of fluid come out, where it doesn't look really pussy, it looks like dirty dishwater. So he's made the diagnosis of necrotizing fasciitis just by doing what he called, a stainless steel scan, which the stainless steel refers to the scalpel that he's used there.
Reappearance to the fascia, and in the OR, you'll see easy separation in the tissue planes.
When do you start your sabbatical?
Tomorrow.
Not a moment too soon.
Thanks for coming down.
What's the status of your septic patient?
Neck fasc. Surgery's taking her up.
Think they'll be able to save her leg?
Right now, I'm just hoping they can save her life.
So now what we've seen here is a progression from a very mild infection, a simple cellulitis, into sepsis, septic shock, necrotizing fasciitis, life-threatening infection, going to the operating room to not just save her leg, but to save her life, because this infection has spread systemically throughout her body, causing multiple organs to fail. Her cardiovascular system, that's why her blood pressure is low. Her respiratory system, that's why she's on a mechanical ventilator. And there are likely other organ systems as well that have been impacted, but we don't have that information, like her kidneys, for example. So this is the story of sepsis and why it's so important to recognize it fast. That's why there are sepsis teams. That's why there are sepsis alerts. That's why hospitals are graded on sepsis, because if you miss it and you don't take these actions fast, you end up increasing mortality. And remember, sepsis is the final common pathway for death from an infectious organism, whether it's malaria, whether it's Ebola, whether it's cellulitis. Sepsis is what we're trying to combat by being really adept at recognizing infections and intervening very quickly. And this is a very good dramatization of what can happen with sepsis. And it's also a very good dramatization of necrotizing fasciitis or flesh-eating bacteria and how quickly it can spread and what it's like to see it basically moving right before your eyes. So I hope that was interesting to you. I think it was a really good vignette from the show.